Sustainability. How do we sustain the successes that we've all collectively worked to achieve? Be that policymakers, program implementers, community, clinicians, governments across the region. So it's a really important issue. So the three of us are going to complement each other in taking different aspects of the topic. Before I get into the topic, I just want to test. Whenever I go out, I talk to a whole range of different types of groups. So I want to just touch on what is the nature of the epidemic across the region. And for each of us, the regions may vary. My region starts in Afghanistan and goes across to the Pacific Islands. So quite diverse region, both in terms of epidemics, in terms of sizes of countries, in terms of a whole range of social, political, and economic issues. So, but to get a sense from you, I'm not sure how am I changing slides?
Let's have a look at this. I think at the bottom it's the pointer.
That one? Okay, great. Okay. So before I get into it, can I just ask the mode of transmission of the epidemic across Asia Pacific? It's always interesting when I go to groups what they think are the priorities. So we usually talk about key populations and types of epidemics. So I just wonder if someone would want to tell me what the main mode of transmission today, because it relates to what Nitya was talking about. When we talk transition, we talk age, we have different variables are coming into the epidemic 30 years on. So what would be the main mode of transmission in Asia Pacific today? Got a group of clinicians. Anybody want to offer?
Sexual.
You can shout out if you want.
MSM.
Sexual. Right?
Sexual?
Mm-hmm.
Right, so sexual transmission is increasingly seen as the main mode of transmission, which is changing. Each country is different. But when I do these talks with groups, I hold this up because to me, this is the main mode of transmission we have to engage with. Right? Now, clinicians find that a bit strange, and that's why, as Nitya said, you don't want to come to me for clinical support. Right? But that is something we really need to think about. Where are we today compared to when we started dealing with the AIDS epidemic? And the dynamic shift in both the age of the epidemic, but where the new infections are occurring, and what are some of the modes of transmission are really important factors we look at when we think about sustainability, because we have to think about what do we want to sustain as well, right? And that's an important question for us to consider. Where are we at in the epidemic? It's varying across the region, but in terms of overall, there has been a very slow decline in terms of new infections. 280,000 new infections currently, but that's nowhere near enough to get to the global targets that the governments of the countries we work in have set to achieve. So we're not achieving that. And we do have rising epidemics in some countries in the region, particularly Malaysia, Pakistan, and Philippines. Philippines has the largest and the fastest growing epidemic in the world today. Over 200% in the last 9 years and 100% increase just in the last 4 years alone. It again is why I held up the phone. 96% of the transmissions are sexual and over 70% of the transmissions are under 24. And if you have Twitter groups of over 1,000 young people, closed groups using internet to connect, that's one of the key elements we need to look at. But we also see countries like Malaysia that have been doing extremely well with their epidemic. And they've got an increase again, significant enough to note. Afghanistan, Bangladesh, Fiji, PNG, one of the biggest factors we've got to look at is complacency. And the whole dynamic when we talk about sustainability is critical to think about what are we taking forward with the epidemic. The right-hand side of this just shows the mix, and 84% is still key populations, as you would have expected with that first question I asked you. Globally, we have a strategy to end AIDS as a public health threat, not to end AIDS by 2030, and sometimes that rhetoric is misunderstood because we can't end AIDS. People will be on treatment for life. But one of the targets of the global strategy is relevant to our discussions today. And it's the overall financial investments for AIDS response in lower middle income countries to reach at least 30 billion, with continued increase in current levels of domestic public sources, ensuring adequate coverage for services for people in need. And that last part is critical too. It's not just money and resources, but where are they being allocated and for what purposes. So it's really important we keep that in mind as we move forward. The context of how we respond to HIV and sustainability, the top, you're familiar with the 3 zeros: no new infections, no discrimination, which is the hardest of all for us to achieve, and 0 AIDS-related deaths. It's in the context of the SDGs, the 2030 goals that all the countries that we're working in have agreed to. And it's not just number 3 on health. It also takes into a whole range, and I've listed another 4 here, aspects that we need to look at when we look at sustainability. We're not just making treatment sustainable. We're not just making prevention sustainable. There's the context of the success of the AIDS response to date needs to make sure we have a multi-sectoral and a multi-dimensional part to it. We need to make sure that, particularly for sustainability, issues of epidemiological, programmatic and financial transition occur, right? And we don't want one over the others. We need to make sure that the transition is occurring across these 3 areas. What do we mean when we think of a people-centered approach? People-centered is the language that you're going to hear more and more when we talk about universal health coverage, when we talk about transition and sustainability. It's to make sure that we're putting the person first. It's not the service, not the health service, not the treatment program that goes first. It's how do we maintain a holistic approach to health for the people that we're trying to serve. This is even more important in the context of universal health coverage. And I know my colleague Naoko will talk more on UHC as we go forward, and I'll touch on some aspects of it. But we have a whole range of definitions of UHC, from financing for health, from treatment programs, and so the definitions are important. We want to make sure that we look on all aspects of what's made the AIDS response a success in countries, and to some extent other communicable diseases have not benefited from that broader multidimensional response. We need to make sure, particularly issues of human rights and protection and community engagement in the response, is not lost as transition and sustainability is looked at. Where are we in terms of the resources for our region? You can see on the right in the red column, we're still not getting to, that's fine. We're still not getting to where we need to be in terms of the overall investments. And you can see here the mix, the growth of domestic financing, both public and private, is clear. But we're also not seeing where is that money spent. And we've still got a major gap in terms of where do we need to get to, and where are we today. So we've got a slow increase in resources, domestic, at the same time a levelling off, and are starting to see an exit strategy by the 2 principal donors, being PEPFAR and the Global Fund in the region, Global Fund being the largest of those 2. And other donors have largely left. And so we're seeing a change in the dynamic of the resource environment for us. So when we're looking at sustainability, we have to keep in mind that we are relying more and more on domestic, but where are the investments going to be put? The other issue that I remember Nitya was saying, some of us have been at this for a long time. 1996, when I took over as the Director of the National AIDS Program for Australia at the federal level, we were always told AIDS was overfunded. Usually what that meant was other health programs were under-resourced for their needs, and they naturally saw a large silo like AIDS having too much. The reality is far from that, as we know when we're working at country level, if we're going to be looking at that multidimensional and comprehensive nature. But the misperception that's out there hampers efforts to get resources, both domestic resources, but also to maintain levels of support for international donors. So it's an issue that we need to address when we're looking at sustainability and transition. The assumption is there's a lot of money already for AIDS, so other areas of the health sector or the health priorities will be addressed first. How do we see the progress across the region in terms of the response? You can see here the Caribbean, Latin America. A big difference just in that part of the world. 72% in the Caribbean is externally resourced for their response compared to Latin America, where it's largely self-financed. Asia Pacific, you can see on the right-hand side, is showing that we are 75% domestically funded. But some of the lower income countries are heavily dependent on donor funding. Seems to be a difference in the transition of the slides. Right, so the middle part of this is talking about the inequities. We need both to look at the scale and the type of funding and where it's being applied. And this, when we use the term inadequate funding, it's often areas of prevention, of the rights, of community engagement are the first to be cut. And that's either by international donors as they withdraw and they're not putting in place transition plans to ensure that these key elements of the AIDS response will be maintained, or they're not picked up by governments. Predominantly international funding has gone to those, but even the scale of the funding that's required for other programs, investments in prevention are not made early enough, and plans are not in place for the transition for that to occur. So we need to be looking at how do we make that mix right as each country moves towards transition. When we look at the broader picture of health, the top bar here is looking at where is GDP spent when we look at health. And we have a mixed bag here. Even GDP in a country like Laos is about the same as Vietnam. But when you look at how much each of those countries spends on health from their GDP, it's a very different picture. The bottom graphs here, the red obviously is the external reliance on HIV financing, and the blue is external support for health in general. And you can see the big disparity here, where a lot of the HIV programs, there's a lot more reliance on external rather than domestic resources, regardless of the increase. And part of that can be attributed to either priorities, or it can be attributed to a sense that the foreign governments are going to help us out with this, whereas they might not be as supportive of other health programs. So governments are prioritising where do they put their investments. This is just an example of a number of countries here across parts of the region. Where's the shift in resources? Right? How much is coming from international versus domestic resources? And you can see there's been quite a significant change in most countries where there is an increase. Some exceptions like Myanmar, which is late to receive international support, let alone increased donor support. I remember the health minister there saying they tripled their health budget, the total health budget. But he said when you triple little, it's not much, right? So the change there is still a long way going, whereas you look at China, it's almost fully self-funded. Thailand's another example where it's not reliant principally on external resources. And we see a mix across the region into how this is playing out. So some gaps are being met by the domestic resources, and that's something we need to unpack to make sure we understand where are we at in terms of what is being spent. This is the reliance here on prevention. It speaks for itself. Where is the domestic funding going? It's going into treatment principally and service delivery. It's not going into prevention. So some may have the attitude that you can treat yourself out of the epidemic, but if treatment is to be seen as treatment as prevention, the scale up of treatment coverage is not sufficient in any of these countries to achieve that, with a few exceptions, and yet sustainability of those countries is critical as well, which I'll turn to in a moment. But you see on the right-hand side here, when we look at areas of expenditure for prevention and the distribution from external resources compared to domestic, we have a serious gap and a serious problem when we're looking at transition. So that's an area that we really need to work on. We have examples like this. I'm taking PNG, but we have examples like this for a whole range of countries. So taking treatment itself, where is the investment going in treatment? So here you can see across the bar, where is the government investing its resources in treatment? The domestic funding here, as you can see, shows that in the cascade, it's mainly on the service delivery of treatment. It's not on the testing and it's not on the adherence, and that's a problem for us when we're looking at lifelong treatment. So we've got to look at also, when we're looking at the increase in resources for treatment, what parts of treatment cascade are the governments investing their funding? So we have a serious issue here to look at, and this slide comes from a PEPFAR analysis for its recent regional review meeting, and we've done this same analysis for a whole range of countries. So if you're interested in others, we have them all available on a data hub which we can give you access to easily. This is another way of presenting the same. Where is the mix of funding going across the 390s? The top one being testing, and then the actual treatment itself and viral load. And if we want to make sure that treatment is prevention, we need to get full coverage of all three of these, getting people into testing so they know their status, getting them into treatment, but then maintaining adherence for life of treatment so that we can see treatment as prevention. So the mix here you can see on the right hand with Thailand and India, much more focus and domestic resources being applied. But you go towards the left and you've got a big difference when you look at the mix of where's the funding coming and what parts of the program are being resourced by them. And this is a serious concern for us as we move forward with transition. And transition is the buzzword. All donors are looking at it. Some move out with little preparation or no preparation. Others have models of how they want to do the transition. Here are the two big ones for us in our region. And if you look at the pie graphs here, there are different areas being looked at by each of them. And this becomes an issue when countries have both programs. So we have examples in countries where both these models have been applied and the results are obviously very different. So how are we going to bring this together when two of the big donors have very different approaches to transition and transition readiness? Quite a number of the countries in our region are already doing assessments for transition readiness. And if it's the Global Fund leading it, you can see the areas it's looking at compared to PEPFAR, where it's looking at a whole different set of criteria. We need to bring these together in a joined-up approach at the national level, and that's critical for ourselves, WHO and the partners at country level to support countries in moving towards the transition. In this slide, looking at health financing, Cambodia is held up as one of our critical success stories when we look at HIV and the 390s. It was the first in the region to be considered that it achieved the 390s. But when you look at where it's spending, on the left-hand side, it's total health expenditure. Right-hand side, it's HIV expenditure. The green is the government contribution. So if you're relying on the transition and the sustainability, and donors are already moving out of Cambodia very fast, we have a very fragile response to HIV in Cambodia, and it's not going to be sustained given government is not investing significantly and now in a staged approach and not meeting the gap. But the other thing to look at is comparing the left and the right hand here is where is the investment. So there's a lot of investment in health, but it's not in HIV. So does that mean they're suddenly going to fill the gap when the donors do withdraw? And the donors will withdraw. And so this is an issue that we need to challenge the countries we're working in to make sure collectively the transition plans are put in place early enough. And you can see China is a very different picture to Laos, but I won't go into the details of these. This one is in prevention. Where are we spending? Cambodia again, look at the pink dots. This is an issue of cost, is another factor we need to be looking at when we're looking at transition. Because it's quite easy to look at the big picture of prevention or health treatment spending, but what are the costs, the unit costs and the program design costs that are elements of this? Cambodia, when we look at prevention, is much higher than the others. And so that in itself, I don't think that's going to work, that in itself suggests we need to look at the model. And what is the cost? Can we afford a Rolls-Royce program as the donors move out and it's left to domestic financing? And this is an issue, and you can see the variation. I won't go through that. And you can see on the right-hand side the same message coming out from different aspects of analysis. So this is another aspect we need to look at, is what is the unit cost of prevention and treatment programs so that when the transition occurs, we are transitioning something that is affordable for the country to take over. Again, when we look at treatment side, it's the same type of issue. Indonesia, why is it so high? Why does it cost so much in Indonesia for treatment for HIV? One of the simple parts of that is the pricing structure of drugs, where it'll cost you 3 times at least the price in Indonesia to buy treatment for one person than it would in other countries. Now that's about domestic policies, so when we talk about transition to domestic finances, if they're increasing their budget but they're not bringing down, having the policy in place to make sure the prices are affordable, they're not going to get the treatment coverage that's required. On the right-hand side, you've got some differences, some realities that need to be taken into account. PNG, if you're doing viral load in a mountainous country with a very spread out population, of course the unit cost is going to be much higher, so that needs to be considered. But then you look at a country like Myanmar for viral load, and why is it so cheap? It's because they've started to look broader than HIV, and they've combined the TB HIV viral load programs, and so they can get an efficiency of scale. So we need to look outside the silo of HIV, and that's a strength of UHC, is if we can stop looking just vertically but start looking horizontally at how we can integrate programs and reduce costs and make them more efficient but also therefore more sustainable across the board. When we also look at what models of delivery are going to be most efficient and therefore more sustainable. Now this sometimes is a challenge, and particularly for our government partners, what areas would they like to fund? Key factors to consider: reaching those left behind, to decongest the health system, which largely means a government system. Community delivery, strengthen the system for improved health and social outcomes for the person, being people-centered approach, looking at convenience and satisfaction and cost. And the bottom graphs here are examples from Vietnam in terms of PrEP, which is a new innovation for prevention, which you'll hear more about over the next couple of days. And the clients prefer the private clinics. So if we want to have efficiency and effectiveness, we need to look at the model. But when we're looking at transition, many of the community-funded programs are not being considered. Excuse me. Which brings me to universal health coverage. We often hear the term universal health coverage, and I hear it everywhere I go. But if I was to do a test of everyone I hear it from, I would come up with 1,000 different definitions of what do they mean by universal health coverage. It's becoming a buzz term. For me, I want to highlight a few things that I see that it is and that it isn't. When we're looking at sustainability and transition, we must look at universal health coverage because it's a critical element of the way forward, as it should have always been in our health programs. But it's systems for health, not the health system response, which I hear in many countries. And so governments, the ministries of health, think it's about their program, whereas it should be looking at the holistic aspect of private, community, civil society aspects of the system. So we need the multidimensional aspect that's been the success of AIDS to be maintained. But in many countries, UHC is going to narrow down and drop a lot of the community parts and the people-centered approach and focus much more on health services and a narrow spectrum of those. So covering the full spectrum, not only treatment, it's about equity, development priorities, the SDGs, if you like, social inclusion. And it's got to be focused at community level. It's got to put the person first, not the health system first. And that's a critical aspect of what UHC is, but we need to make sure that it's understood well. It's not just about health financing. It's not just about a minimum package of services and treatment services at that. I was in one country where they were doing the minimum package approach analysis, and people were putting down syringes and commodities that they would require in treatment services. So they weren't looking at the full package. There was no reference to prevention in that discussion, and that was within the Ministry of Health. So we really need to broaden the understanding of what we need to ensure are part of this. And it's about individual health. It's looking at the people first, not the service first. So I'm coming to the end to bring this together. To go back to the beginning, we need to be looking at where are the health programs when we're looking at sustainability in the broader context. It's both the health system strengthening and the community system strengthening that have both been the critical success factors for HIV. We wouldn't have the response and the success we have to AIDS today if it wasn't for the community voice, the community participation, the patients understanding what their treatment needs should be and demanding the right type of services and support, but also that treatment adherence. The community role cannot be underplayed, because that's been one of the failures of some of the other programs in communicable diseases. The Prime Minister of Thailand recently held an international meeting on NCDs, non-communicable diseases. And he told them he wanted to look at the AIDS model that Thailand had put in place. Not the disease, obviously, but the model, the multi-dimensional model. If he was said, if you're serious about NCDs, you're going to have to look at this at a comprehensive, multi-dimensional approach. So there's a Prime Minister who's not a health practitioner, not a clinician, not a public bureaucrat, and he saw the value of the model. So if we're going to transition, we need to make sure all dimensions of this is understood in the health systems for health approach. AIDS, UHC, SDGs are all multidimensional. The role of civil society and the private sector is critical, and we're seeing in a number of countries the role of the private sector as a healthcare provider increasing, and we need to make sure that we're working with them to have them understand the comprehensive nature of what's needed for communicable diseases, not just for HIV. So the community system strengthening is a must, and the people-centred approach. And this all leads, the governments have all signed up to Sustainable Development Goals, but often compartmentalise them. Like much of health today is separated, and we don't look at the whole person, we look at just one aspect of their health. So we need to make sure they keep the broad context if true sustainability and transition is to occur. And in conclusion, UNAIDS also looks at the model of what are the areas we need the criteria. So I put up Global Fund and PEPFAR before. Now on the right here you see the 5 components that we think are critical. So we need to look at overall domestic funding levels. Where is it being spent? Making sure that equity and application of the resources is there, and that we're making sure that all the dimensions of the response to AIDS are funded. And we need to make sure that we're tracking the policy changes to make sure that we're going to see an impact of the interventions. And this is in all parts, in prevention and in treatment. Where are the funds being applied, and making sure they're going to have the impact on the epidemic itself, and not just looking at components. The models of service delivery are critical, and we can't slip back into a biomedical response to AIDS, because that will see increasing new infections in countries. The trends, the human rights, we see that shrinking across the region, and it's becoming a greater challenge. It's almost going back to 30 years ago in some countries in the discussions about the right to health and people's human rights and protecting those. It's been a critical part of the response to AIDS. We need to make sure that that's sustained as we transition to domestic resources. The human resources, this is about the task sharing that needs to go on and needs to increase. So we break it down and demedicalise treatment and other components. And the options here, decentralised, what's the role of the private sector, and insurance. And we're going to hear more about some aspects of these from my colleagues who are speaking after me. So this is a broad overview of different components. When we talk simplistically about sustainability and transition, there are many different elements that we need to dig into, and we need to do it comprehensively and in a joined-up approach between the various actors supporting the transition at country level. Because the big risk is that we're going to slip backwards, and we're going to see increasing new epidemics in countries that have had success but been reliant largely on international resources for critical components of their response. So thank you very much, and I wish you well over the next few days.